Two patients, same organism, same antibiotic, same daily dose. One receives it as a 30-minute bolus, the other one over 4 hours. In 2026, there is no longer a pharmacy detail. It's a strong recommendation. I'm Dr. Raza. Welcome to my Clinical Med Ed channel. I'm an MRCP examiner, and this episode 3 of 5 on what actually changed in Sepsis 2026. Today, beta-lactam antibiotics and why prolonged infusion, think of Brady, slow, prolonged infusion now matters. We'll cover the pharmacology, the trial and clinical evidence behind the upgrade, and exactly how to write the order tomorrow morning. Please stay till the end. The loading dose is a step most people miss, and that's where the exam marks are actually. So this is the timeline for the Sepsis 2026 video series. We started off with a whole comprehensive 5-change summary video, which is already online. Then then there is a 5-part full details of each of these changes. Episodes 1 and 2 are already live. One covered the screening tools, why QSOFA is out and News 2 is in, and similar newer screening tools. Episode 2 was about the fluids and fluid resuscitation and the guidance and the evidence behind it. So this is the episode 3 where we are right now on antimicrobials, antibiotics, beta-lactam use, prolonged infusion, and the rationale behind it. And the future upcoming 2 videos will be on vasopressors, episode 4, and the target map, especially in elderly population, and the de-escalation and antimicrobial stewardship, which some of the points we will discuss in our current episode as well. So please stay tuned, and ideally, if you can watch all 6 videos in a sequence, that will be great because each episode links with the other. So looking at the learning objectives, this video, like other series, has 2 parts. Part 1 is the science and the theory, the mechanism and evidence of antimicrobial use, and the part 2 is the clinical application of the same knowledge. In part 1, we will discuss about the beta-lactam and the pharmacokinetics and dynamics, about the minimum inhibitory concentration and the time required for them to be above the MIC, not the peak concentration, and the rationale behind it. And also the clinical evidence from the different trials, BLING III, MRCP, and the meta-analysis, which was done in 2024, which found the pivotal basis for some of the recommendations. And finally, we'll touch upon some of the key beta-lactam antimicrobials, which are considered for prolonged use, their dosing, stability, some of the practical applications, which is very, very useful, and I'm sure you will enjoy it. Similarly, part 2 of this video will cover the clinical application of these theory points that we discussed. Basically, surviving sepsis campaign 2026 recommendations, the wording, the grading strength, and the loading dose first rule. That is really important. Antimicrobial stewardship, blood cultures, when to de-escalate, which is now a strong evidence, and the shorter duration of the total antimicrobial administration in terms of the length of, the treatment length actually. And selective digestive decontamination, SDD, a conditional suggestion based on resources and resistance pattern. We will come to that. And finally, some MRCP examples, MRCP USMLE exams about sepsis, infection, antimicrobials. We'll touch upon the MIC and the percentage of time spent above that MIC concentration, the stability data, and the 3 agents most likely to appear in your exams. So beta-lactam antibiotics remain the largest and the most widely used antimicrobial class, including penicillins, cephalosporins, carbapenems, and monobactams. If you look at the first column, the target of these antibiotics is the penicillin binding protein, the PBP, and these are the transpeptidase enzymes which cross-link the peptidoglycans, and that leads to the bacterial cell wall strength. In the middle, you have the mechanism of kill. So basically, the antibiotics have a terminal D-alanine. It mimics the D-alanine structure, D-ALA structure of the normal substrate of the bacterial cell wall, and hence it mimics that and it covalently binds to the penicillin binding protein, the active sites of the PBP. And that leads to the blockage of the transpeptidation, which should normally lead to cell wall stability. And due to that, the bacterial cell lysis, due to the osmotic instability and cell lysis, and death occurs. If you're coming to the mechanisms of resistance, bacteria are smart and clever. So what do they do? First of all, they create enzymes, beta-lactamases like ESBL, extended spectrum beta-lactamase, and also AMC, which is ampicillin resistance locus C specific structural gene. Third is the KPC hydrolase, which is Klebsiella pneumoniae carbapenemase. Now, all of them, they inactivate the beta-lactam ring and hence they inactivate the drug itself. So that's direct destruction. The other is bacteria altering the target penicillin binding protein so that the antibiotic doesn't attach or connect to the bacterial cell wall itself. So this is mechanism by the MRSA bacteria. Thirdly, the antimicrobials are hydrophilic, so they have to travel through the cell wall inside the bacteria to be able to accumulate in certain concentration and destroy the bacteria. So what do? They some of the bacteria, they reduce the porin activity, because if they stop producing the porin and or fewer porin channels are available, so that and hence that will lead to reduced accumulation inside. And that's why Pseudomonas acinetobacter, they reduce drug accumulation through porin loss and efflux pumps, which means, so the key pharmacodynamic principle here is that the beta-lactam killing of the bactericidal effect of these antimicrobials is time dependent. So the longer they stay above the minimum inhibitory concentration, the stronger their effect for the bactericidal activity. And it doesn't depend upon the concentration above the MIC. This slide is one of my most favorite. It compares the two main antibiotic exposure mechanisms. First, on the left side, the green box is the time-dependent killing for antibiotics like beta-lactams. And the key pharmacokinetic and dynamic index in this situation is the free time above the minimum inhibitory concentration, which means how much time do the free drug stays above the minimum inhibitory concentration required for that bactericidal activity. So, or which is the FT greater than MIC. Now, once the concentration is adequately above the MIC, pushing the peak, like achieving a higher concentration above MIC, doesn't add any pharmacological or clinical benefit. Now, what matters is how long the active unbound drug remains above the threshold. So how long does it stay in that window? That matters more. That is why more frequent dosing and extended infusion dosing or continuous infusion can improve the target attainment, especially in critically ill patients. Now, a caveat to this is the strong recommendation of giving the first dose as a bolus. Do not give it as a slow infusion, because you want to achieve the maximum bactericidal activity upfront. Right hand side of the graph, the orange one, you see it's the concentration or exposure dependent antibiotic benefit from either a higher peak or sufficient total exposure. Now, typical aminoglycosides are mainly in this category, where you have the Cmax, the maximum concentration to MIC is required, typically gentamicin, and the target is usually 8 to 10. And that's why we have a very narrow therapeutic window to achieve. Otherwise, it can lead to nephrotoxicity and more problems. Fluoroquinolones are better assessed, and also metronidazole better assessed as area under the curve to MIC, reflecting a 24-hour exposure rather than just the typical concentration. So how does it practically affect all of us or you in your clinical practice? Beta-lactams need sustained exposure, while aminoglycosides need an effective peak, often supported by a post-antibiotic effect. Now, once again, this is an educational resource, a guidance, a tool that I'm sharing based on the best practice evidenced in the Surviving Sepsis Campaign 2026 guidelines. However, use your own local policy, institutional policy, and your own standards of practice, because this guide is for educational purposes, not a replacement of what you people have to do on a daily basis. Okay, bolus versus prolonged infusion. What is the mechanism? First of all, the loading dose rule is the clinically most important here as a practical point. Why? Because giving loading dose IV bolus over 15 to 30 minutes and then followed by prolonged infusion actually helps. The reason is that without the loading dose, the prolonged infusion will take time to build up slowly and the MIC. And in a patient in septic shock, you do not want to wait for that particular time. And the bactericidal activity has to be the concentrations have to be achieved within 1 hour of treatment initiation rather than 3 to 4 hours. Why same dose works better? Because the time spent above MIC of from 40 to 50% is in a bolus versus 70 to 100% for prolonged infusion dramatically improves the pharmacodynamic and the target attainment for the effect plus the bactericidal activity. And this is more pronounced for medications like, when the MIC is elevated and Pseudomonas and intermediate susceptibility, where they have intermediate susceptibility to piptazo, and then you need a prolonged MIC for the antibiotic to work properly. And that's why the first dose has to be given. It's critical that the first dose has to be given as soon as possible rather than as a bolus rather than infusion. And subsequently, the same guidelines recommend frequent dosing, prolonged infusion, depending upon the local protocols and policies. Again, okay, bolus versus prolonged infusion. What is the mechanism? First of all, the loading dose rule is the most clinically most important here as a practical point. Why? Because giving loading dose IV bolus over 15 to 30 minutes and then followed by prolonged infusion actually helps. The reason is that without the loading dose, the prolonged infusion will take time to build up slowly and the MIC. And in a patient in septic shock, you do not want to wait for that particular time. And the bactericidal activity has to be concentrations have to be achieved within 1 hour of treatment initiation rather than 3 to 4 hours. Why same dose works better? Because the time spent above MIC of from 40 to 50% is in a bolus versus 70 to 100% for prolonged infusion dramatically improves the pharmacodynamic and the target attainment for the effect plus the bactericidal activity. And this is more pronounced for medications like, when the MIC is elevated and Pseudomonas and intermediate susceptibility, where they have intermediate susceptibility to piptazo, and then you need a prolonged MIC for the antibiotic to work properly. And that's why the first dose has to be given. It's critical that the first dose has to be given as soon as possible rather than as a bolus rather than infusion. And subsequently, the same guidelines recommend frequent dosing, prolonged infusion, depending upon the local protocols and policies. Again, I cannot overemphasize, please follow your institutional policy or local antimicrobial guidelines or your infectious diseases colleagues, whichever the case may be. One of my very favorite slides, the real practical prescribing protocol regarding the antibiotics, beta-lactams, and sepsis, septic shock, and the pharmacology behind it. So the three-step protocol, we have discussed this before, which is the clinical takeaway from this episode. Number one, the step one, the loading dose bolus, irrespective of subsequent infusions, has to be given same dose as standard and given quickly. Step number two, prolonged infusion, same dose as per administration, but extended duration of administration over 3 to 4 hours again, depending upon the drug's stability at room temperature, etc., etc. And step number three is the optional one, which is a continuous infusion, as we have discussed in the previous slide about ceftazidime and prolonged therapy if anticipated. Now, renal adjustment caveat has to be considered for sure for prolonged infusion changes. Because it will change the infusion rate, not the total dose. That's number one. In acute kidney injury, the reduced total dose first and then apply prolonged infusion to each subsequent dose. Again, the clinical pharmacologist or the pharmacist, clinical pharmacist will be able to pick it up and guide it for us. Sometimes we have an online electronic calculators and built in electronic health record systems, and they can calculate the dosing accordingly based on the patient's EGFR and renal profile. Cefepime, we have discussed before, neurotoxicity risk, encephalopathy, myoclonus, and seizures, especially at supratherapeutic levels. In EGFR, in patients with EGFR of less than 30, the dose reduction is mandatory. So, and one other final tip is that IV compatibility. So, the Y connectors, the Y site, some drugs may not be compatible. So, piptazo and meropenem are incompatible with many drugs. As again, please check your local pharmacy formulary. Your guidelines from infectious diseases colleagues. And so let's look at the exact antimicrobial recommendation in the SSC 2026. So it reads, we recommend using prolonged infusion of beta-lactams for maintenance after an initial loading dose over bolus administration. Again, prolonged means extended over at least half an hour of the dosing interval or continuous infusion. Both are included. the loading dose first principle is always explicitly part of the recommendation, so no compromise on that. In terms of scope, the recommendation is for beta-lactams broadly, not a fixed drug list. Benefit is greatest for short half-life agents like peptides and carbapenems. The four agents in this episode, as we've discussed previously, are the common practical choices, but not a formal SSC scope. Please remember that. Amoxicillin, aztreonam are not formally excluded in the text. So again, once again, it comes back to the same point of using your local policies and guidelines and antimicrobial protocols, whichever the case may be. Let's look at the new condition suggestion about the selective digestive decontamination. Basically, oropharyngeal and GI decontamination using non-absorbable antibiotics, for example, colistin, tobramycin, or amphotericin B paste, with or without short IV antibiotics, is in mechanically ventilated patients to reduce ventricular-associated pneumonia and ICU acquired bacteremia. This is it's new in this policy, in this guidelines. However, it's mainly recommended in settings where there is low prevalence of antimicrobial resistance, and this is with moderate certainty. The evidence stems from the 32 RCT meta-analysis in 2022, which showed a probable mortality reduction. The newer study again later on published in New England Journal of Medicine in 2025, the SUDIC ICU or SUDI ICU, SUDD ICU. It found a similar 90-day mortality with fewer new bloodstream infections and fewer resistant organisms. Now, the main thing is the guideline does not say that selective digestive decontamination is contraindicated in high resistance settings, but it limits the suggestion to low resistance units and says that in high resistance settings, individual benefit of the using this approach must be balanced against the resistance profile. In terms of, I think, where does it apply? It applies to most of the Middle East region, South Asian countries, countries with low and medium income settings, economies. In those ICU settings, there may be high baseline resistance. So selective digestive decontamination balance has to be, think of the Argentum. You have to balance the probability of individual benefit versus the antimicrobial profile of the area, region, country, etc. Okay, let's look at some of the stewardship upgrades about blood cultures, the de-escalation, and the duration of antimicrobials. Now, if you look at the blood culture statement 7, it's a strong recommendation to collect blood cultures as soon as possible, and ideally before antibiotics are administered, but never delay antibiotics to obtain blood cultures. This used in 2026. They also sort of defined or about the number of blood culture sets and use of anaerobic bottles. It should be individualized. It's not a hard and fast rule, but usually speaking, in most settings, we recommend taking a paired bottles of blood cultures, both aerobic and anaerobic. And there is no 45-minute rule in the guideline, as generally it's a misnomer that, it has to be within 45 minutes. But again, as I said, the general best practice is within 1 hour, although the SSC 2026 doesn't put any, strong timeline as such, really. In terms of the de-escalation, the second column, it's upgraded to a strong recommendation, which means once you have microbiological diagnosis and susceptibilities confirmed, then you need to de-escalate as soon as possible. Although it's very low certainty, but strong recommendation. We will discuss about the de-escalation in our episode 5 of this series, the last episode. Again, in terms of duration, the same principle applies. It's a conditional suggestion, which is the shorter over longer duration and source control once that is achieved, although it was not upgraded. Now, the new supporting evidence comes from different studies, also, in the guidelines. Similarly, the procalcitonin use with clinical judgment, not on its own. That's one thing. Of the three, only the de-escalation was upgraded. Out of all these policies, the de-escalation was upgraded. The rest were retained at the same level. So this is a busy slide. But again, if you just follow, basically the blood cultures before antibiotics, if possible, if appropriate, but do not delay antibiotics. Number 2, de-escalation of antibiotics once we have the cultural results and sensitivities. And finally, the duration is guided once again by your local policies and protocols, but de-escalate and quantify the duration or specify the duration based on the source and the type of infection really. Let's put everything into practice. I really like this slide, and it will be useful from your MRCP and exam scenarios as well. So first of all, prolonged infusion. Second is de-escalation. Third is the duration and the procalcitonin in use. I'm not going to read all the scenarios, but the first one is about a community-acquired pneumonia based on Pseudomonas requiring ICU admission, and then 68-year-old lady ventilated, septic shock, and the bronchoalveolar lavage grows Pseudomonas. Now, as per the guideline, pip-tazo bolus first, then followed by prolonged infusion, and check the stability at the room temperature. And daily dosing will be roughly like 3 times a day dosing based on the normal renal function. Second scenario, ESBL, Klebsiella, Eurosepsis, step down from ICU. The patient is improving. On day 3, you receive cultures. The patient was on meropenem already, but now the cultures show that it's ESBL, Klebsiella pneumoniae as an organism and sensitive to both mero and ERTA. What would you do? Better to de-escalate to the narrow spectrum. So instead of meropenem, go to ertapenem 1 gram intravenous once a day, which is a narrower spectrum, and also it's once a day administration. No pseudomonal coverage is needed as per the cultures, and review the duration at day 7 and then consider stopping. So again, the guideline is, or the recommendation is, do not use the broader spectrum like mero once you can use a narrower spectrum like ERTA. Finally, a third patient ventilator-associated pneumonia, day 5 cultures, all negative so far, procal trending down from a peak of 42 to now 4 nanograms per mil. What would you do? Again, based on the guidelines and recommendations, 5 to 7 days of treatment is sufficient, and procalcitonin is already improved by more than 80% from the peak, and clinically improving. Afebrile ventilator settings are stable, white cell counts are normal, and vasopressors are not needed. So again, use your local policies, guidelines. I'm just putting this slide up as an educational resource of guiding you. You can pause, stop here, read the slide, absorb it all in, and then you can proceed to the last slide of this particular video. So the final slide in this video, what's new, what's retained, and what has been considered to be like downgraded or to be reconsidered. So I'll read from right to left. So the new and upgraded first. So the first evidence for the new one is that the prolonged beta-lactam infusion is upgraded. The evidence is upgraded from conditional to strong, but remember, loading dose first and then continuous infusion. Number 2, in the same category, is the de-escalation. The recommendation is upgraded to strong when a confirmed organism and susceptibilities are available. And the third one is a selective digestive decontamination. It's a new conditional suggestion, mechanically ventilated patients, but in low resistance units only. Coming to the middle, the green, the retained one. Blood cultures before antibiotics, it's a strong evidence, but never delay antibiotics to, strong recommendation, but never delay the antibiotics to collect blood culture. So that's the key thing. And empirical antimicrobials in septic shock, ideally within the first hour in septic shock, and within the first 3 hours in possible sepsis. But again, follow your local guidelines and sepsis bundles as the case may be. The one on the left side is, I wouldn't call it deprecated, but it's more downgraded and to reconsider, which is the rigid empirical prolonged broad spectrum antibiotics when cultures are back and there is no de-escalation policy. So again, that is not recommended. And the old 2 sets, aerobic and anaerobic for everyone rule, has now been changed to individualized approach in terms of number of sets and anaerobic bottle cultures, how many to take. Again, follow your local guidelines. But shorter antimicrobial duration remains a conditional suggestion. It's a carryover. It's not an upgrade from the previous recommendations in 2021. And with this, I thank you for staying tuned to this episode 3 of the Sepsis 2026 5-part series. It's a 6-part series. First one was summary, but then each of the 5 changes we are discussing. And the next episode, episode 4, which is the second last episode, will be on vasopressors and the elderly mean arterial pressure targets. So please stay tuned and feel free to share your comments or any suggestions or anything that you want to see in future on our channel. You are most welcome.